To continue our discussion today of the sort of principles of psychopharmacology. I know we're spending a lot of time on this chapter, and you're probably like, I definitely want to look at other chapters, and we will. But this is I feel like if you don't know how drugs get into your body, move around in your body, get metabolized, and then out of your body, I don't feel like really you're going to get a lot of the rest, right? I feel like that's important because this sort of 4 or 5, some people do it in 4 steps, some people do it in 5 steps, kind of depends on how you want to think about these things. If you don't really think about these steps, it's just not going to work. And we can apply these steps to every single substance that we discuss, right? Every substance that you put into your body is going to go through this same process, right? Whether you're presenting on alcohol or ketamine, right? We're going to go through the same sort of basic structure of this process. So really understanding this, driving this home, this is going to be what's important to you, right? This is going to be what you're going to be able to apply going forward, because somebody's going to ask you when you're doing your presentation, like, well, what determines the bioavailability of this particular drug that you're discussing? And you're going to have to come up with an answer, right? So I'd be ready to talk about that when you give your presentation, okay? Somebody's going to say, is this a prodrug or is this an active metabolite? You know, it's one of the things, like with heroin, you don't realize heroin breaks down to morphine, right? And so that's something I know, right? Natalie, I mean, you're really perplexed by this. You don't think about those things, right? You don't think about these sort of prodrug situations and so forth. So we want to make sure you have a handle on that, right? So we're going to really slow down now. We're going to speed up through a few things soon, so be ready for that. You guys are going to have to do some legwork at home, right? We already said Chapter 2. Not going to talk about it at all. So how many of you have read Chapter 2? Okay, I know like 4 or 5 of you don't have to read Chapter 2. The rest of you, I don't know. Okay? Kaylee, you're on the list. You don't have to read Chapter 2. I know, right? You're excited about that. Okay. So again, if you've taken physio, you probably don't have to read Chapter 2. Even if you've taken like human anatomy and physiology, you probably get by with just skimming Chapter 2, right? Because there should be some stuff you cover in that class about neurons and how they work, right? So it should be okay. If you're not, where can you go for help? You can ask me questions. You can ask Montana questions. Or you can go to the YouTube channel I showed you and look at the lecture for Chapter 2 from Physio. It's the same chapter number. Try not to confuse you there. Structure and function, and there's a nice couple-hour discussion there, right? So it's kind of up to you. You can read the chapter, or you can just watch that video or listen to it. Or if you're in the class, right, Emily, just show up Wednesday. We'll get you squared away, okay? I would say you could show up Wednesday even if you're not in the class. I don't have any room in there. I'm hoping fewer people show up. I'm in room 130.
In science building?
This building. With 50 students. 50 students are enrolled. Yeah, it's tight. I thought they would give me the 134, the angled room, you know, with the stadium seating, but no, give me the flat room.
It's a much nicer room.
It is a much nicer room. There you go. Okay, so we've administered a drug. How did we administer that drug? Well, you just pick your favorite way. It doesn't really matter, right? You could have inhaled it. You could have injected it. You could have rubbed it on your forehead, right? Because we talked about topical administration. Okay, so there are many ways you can get a drug into your body, right? Now it's in your body. Okay, we're getting it there. What contributes to this sort of absorption, like how we get it into the blood supply? I mean, there are a bunch of things that are important, right? Because we really want to get this to the brain. And we already talked about how your brain has a protective wrapping, right? And for our purposes, we're going to think about that blood-brain barrier as that protective feature. We're protecting the brain by closing up the capillaries, the blood vessels, right, that are in your brain and preventing them from being leaky. The whole job of a capillary is to be leaky, right? It needs to dump stuff out. It needs to pick stuff up. And that's generally how things work in the rest of your body, right? When you're delivering nutrients to your heart, your lungs, your liver, your toes, whatever, you want those nutrients to fall out easily of your capillaries and be picked up easily, the trash picked up easily, okay? So you want that exchange to happen. When we get to the brain, we don't want that just free flow of molecules, right? Your brain is a very delicate organ. It's a very sensitive organ, Okay, and we want to be careful what we allow in there. Right? So we talked about some of those barriers. We talked about the placental barrier, and we talked about the blood-brain barrier. Right? So we're going to think about the blood-brain barrier. One of the top things that's going to affect whether that drug gets through is whether or not it's lipid soluble. Right? And lipid solubility, I say this is one of my keys to transcendental enlightenment. Right? And what I mean by that is once you understand lipid solubility, there's so much about the biological world that just makes sense. Right? There's so much that just falls in place. There are a few other things. Surface area to volume ratio is another big factor that we'll think about at some point when we need to. But this lipid solubility business is central to how most of your body works. Now, why is that? Well, that's because your cell membrane is made out of phospholipids, right? And we talk about the phospholipid bilayer, right? Sometimes it's referred to as a mosaic. Okay. Why is it a mosaic? Well, there are different little proteins and things embedded in that, and we'll talk about those when they're important, right? But essentially, you have two parts of your phospholipid, right? You've got the head of the phospholipid, which is hydrophilic, right? Which means it loves water. It's got this negative charge to it, right? It's like, I love water. And you have a hydrophobic region, these two tails, that actually hate water. And they're like, we don't want water at all. And so what happens when you put a bunch of phospholipids together, they'll actually self-assemble into this bilayer, right? If you put them in an aqueous environment, okay? Because the heads love water and the tails don't, what's happened is two tails will go together and go like, guess what? If we kind of put ourselves lined up just right, we'll never have to touch water. And we'll have those crazy guys on the outside, right? Those negatively charged heads who love water, right, Jillian, for whatever reason, you're crazy. They'll be out there exposed to that aqueous environment. Two tails will be in there protected, right? And so you create this phospholipid bilayer, kind of structures into a sphere. So what you essentially get are a number of these side by side, right? And then you get them on the bottom side. And they're packed in there pretty tightly, okay? So how do you get through here? Well, there are a couple ways you can get through. One, you can be really, really small. Okay, so let's imagine you're small and you're uncharged. Something like oxygen, for example, right? O2 might slide in there. A big one that we'll think about is nitric oxide, right? Nitric oxide is a great signaling molecule in your brain. It's a great sort of feedback about if another cell has done something, it'll send a little nitric oxide back to you, right? Okay, so nitric oxide can slide through there, so that's great. If something is lipid soluble, it'll slide through there, right? Again, we talked about something. These are two separate concepts. I don't want you to think I was saying no alcohol. Alcohol is lipid soluble, right? So alcohol can pretty easily slide in and out, right? I don't have to answer this question, but I'm going to assume the majority of people in this room have ingested alcohol. I think that's a safe assumption, right, Emily? I mean, looking at the demographics of the situation, it very quickly got in. You're surprised by that, Natalie. Like, you don't think the majority of the people in this room have ingested alcohol. I would assume so as well, right? So that alcohol very quickly slides through the phospholipid bilayer, right? Gets into your brain, starts screwing around with what's going on in there. We'll talk about that quite a bit later, but just think about how easily that gets in. The other way that you can get in and out of this phospholipid bilayer is through a channel. Okay, and so later we'll talk about ion channels. Okay, so even though something is small, like sodium, because it's got that charge on it, it's not gonna get through that phospholipid bilayer very easily. And so we have to have a special channel for that, right? We call that an ion channel. Why? Sodium's an ion, right? And so that's how that would work. So we'll think about ion channels and such later. But those are really your three ways through the phospholipid bilayer. You got to be small and uncharged, okay, like nitric oxide. You have to be lipid soluble, or they've got to make a special door for you, right? Those are the ways you're getting in, okay? There are a couple other things we could think about with how we get glucose in there and astrocytes, but again, it's coming through some sort of special mechanism, right? So we can think about that. All right, here's kind of a good, piece of your phospholipid bilayer. You've got parts on the outside, we call it extracellular. You've got stuff on the inside, intracellular. These are the proteins that are embedded in there, right? What are these proteins? These can be those ion channels that open and close, let ions come and go. You can let other molecules move back and forth, okay? These guys work as receptors. They can grab on. Think about how they're going to grab onto the drug molecules that you put in your body or the molecules that are already produced by your body that operate those same receptors, right? This could be an opioid receptor, for example, right? And it's going to be activated by either your endogenous opioids or by the exogenous opioids that you take, right? Whatever drug that is, let's say some kind of morphine-based painkiller, right? Okay. We want to think about diffusion for lipid-soluble drugs. If you've ingested a bunch of alcohol, it quickly got out of your stomach and into your blood. It's lipid-soluble, so it just slid right in there. High concentration in your blood, low concentration in your brain. Through passive diffusion, guess what's going to happen? It's going to diffuse out of your capillaries into your brain, and there you go, right? Then it's going to have its effect. Okay. Larger concentration gradient, faster diffusion. It's that simple, right? If you put a lot more alcohol into your stomach at a given time, it's going to move out of your, it's going to move faster, right? Because the concentration's higher, okay? Again, lipid solubility, how fast it's going to be, how fast it's going to get in the brain. Heroin, why does heroin work so much more powerfully than morphine? It's more lipid soluble than morphine, right? So it actually gets into your brain more easily, more readily, right? Okay, so that's how that works. Get a quicker onset. We talked about ionization. I don't want you to get bogged down too much with this, like this pH and pKa business. You do want to think about this some, right? Drugs can be ionized when they're ingested, when they're put in your body, when they're exposed to different environments. Different drugs are changed in different ways, right? And if they become ionized, it means they carry a positive or a negative charge, right? When they're ionized, that makes them less lipid soluble, right? It's going to carry a charge, okay? So if you can ionize a drug, then it's not going to be as likely to get into your brain and cause problems, right? Or cause benefits, either way you want to think about it. Here's some examples of pH. If you guys are not familiar with pH, spend a little time on it. It's not too big of a deal. They're going to tell you this whole business about weak acids and weak bases, and I don't really want you to think about this a whole lot, right? This is, if you're really interested, feel free to read this, right? It's probably a bit more than you need at any given moment, though. But keep in mind, drugs can be ionized. Some drugs are ionized more than others. Depends on the chemical structure of the drug and the environment in which it finds itself, okay? Those two play together. Here's just an example, different environments, whether something's ionized or not ionized, okay? All right. What are some other things that affect absorption, right, besides that lipid solubility business? How quickly your stomach empties, right? Okay. The small intestine is going to do more absorption because it has a big surface area, right? And things move through more slowly. So you're going to be more, it's going to be easier for you to pluck out things as it's going through the small intestine, right? You go into the stomach, it's like this, stuff squishing around for a couple hours, and then it's out, right? You don't have a lot of time to absorb stuff. You don't have a lot of surface area. Your intestine, anybody know how long your small intestine is? It's like 1,000,000 miles long compared to the stomach. That's not the right answer, but it's, yeah, it's pretty long, right? I mean, your intestine is pretty long, okay? And it moves through there slowly, right? How quickly does stuff get out of your stomach? Usually we say a couple hours, right?
20 feet.
It's 20 feet? Okay. Small intestine's 20 feet, not 1,000,000 miles. Well, there you go. Guess I was wrong on that. But how long's your stomach? Like 5 inches? Sounds reasonable, right? Sounds reasonable. We'll go with that. So your stomach's quite small. Your small intestine is quite long. Stuff moves slowly through your small intestine, right? Something is out of your stomach in about 2 hours. In general, start to finish, digestion takes about 24 hours, right? Only 2 hours of that was in your stomach. Where's the rest of that time? It's your small intestine and then a bit in your colon, right? So much more time, much more surface area, okay? So we can do that. Size and sex of the individual is important, right? Larger individuals obviously have more body fluid to dilute a drug. I always wonder about this when I say this when I take Advil, right? Because they're like 12 and up, take 2 Advil. And I'm thinking, I'm as big as like 3 12-year-olds. So should I be able to take 6?
I mean, you can take up to 8 at one time without like causing serious problems.
Correct. But I wonder about, do you ever think about those things? Like, my nephew's 12.
Yeah, because we sell lots of like children's products, and under 2 you can't sell the product without like a prescription from a doctor.
Correct.
But what's the difference between a 2-year-old and a 3-year-old? You know, it's
right.
Like, why is that the cutoff? So I do think about that actually quite often. Why those limits are so arbitrary.
Yeah, yeah. And shouldn't there be a chart on the back, like where I can calculate my like height and weight and body fat, and then figure out how much of the drug I need to take? Like, here's a range. Like, you know, I just think about my nephew who's 12 and he weighs like 70 pounds. I don't know how much. Is that a normal 12-year-old weight?
No.
No? How much do 12-year-olds weigh?
Like 100 pounds.
I don't know how much he weighs. He's thin. He's not
70 pounds
malnourished.
is like a 6-year-old.
Oh.
Yeah, my brother is 8 and he's like 65 pounds.
Oh, okay. Well, what do I know? So let's say he weighs 100 pounds. Is that better? You feel better about that? 150 pounds? I don't know, but there's like some difference, right? Like by the time you go from, I don't know, I think about those things, right? I watch these commercials with Shaquille O'Neal, and he's like rubbing on the icy hot, and I think, how much Advil does that guy have to take? I mean, he's like 7 feet tall, 300 and some pounds. He's taking more than a 12-year-old. Right? I mean,
have you ever seen him hold like a water bottle in his hand?
I know, right? So he's got to take. I mean, it just, you think about these. Just a fist. One of his fistfuls or a regular person's fistful?
Like a regular person.
Like a regular. Okay.
He must use like half the jar of icy hot when he goes for it. That's a lot of surface area.
I know, right? I mean, I'm thinking about that. I'm like,
That's why he's the sponsor, so he can get more.
he's like, don't pay me. I just need free icy hot. This is breaking me up. I don't know. I think about those things all the time, though. As I'm sitting there and watching them, like, huh. I don't know.
Is there like something in the drug though that can cause harm regardless of size? I don't know.
I mean, insects cause a lot of like GI distress, and they decrease prostaglandins, which will reduce your mucosal lining in your stomach, which is where you get the GI distress from.
There you go.
So.
Yeah.
Technically, yes, but if you're not taking them like every day for an extended time, it's not a problem.
So there you go. Half a bottle every other day, you're fine.
Give yourself a break in between.
Yeah. You got just switch from Advil to Tylenol. It's fine. Is that good advice?
No, that's not good advice either. Because you can impact your kidneys with the Tylenol, which is a totally different thing.
Okay, so then every 3 days do Tylenol, and then you've got your Advil, and then you get a day off. We could work in some other kind of pain reliever, right? Just aspirin. There you go. That's fine. Come on, Emily, give us something.
The aspirin's even worse. Like, don't get me started on aspirin.
Yeah, we're not going in the right direction.
You're going in the wrong direction.
Yeah. All right, so there you go. So size makes a big difference. Females also tend to have less body fluid than males, and so that makes a difference as well. Keep that in mind. Maybe you should get one of those scales that tells you like how much. You ever seen those, like those? You know what I'm talking about? It tells you like your water and your fat and so forth, your percentages, and then calculate. In fact, I mean, Tylenol is like something like you don't. I mean, or Advil. These are things that your therapeutic index is kind of wide on that, right? So if you go in and you're like, oh, you know, I'm bigger than a 12-year-old and I decide to take 4 Advil, once in a while, probably not going to hurt you, right? However, if you are in a much more, let's think about a situation where they're giving you a drug that might be more powerful, right? Think about something like an anesthetic. In that case, you might want to really have a good idea about how much you're giving someone, right? Cutoff's not, well, if you're over 12, this is how much gas we give you. This is why when you have a surgery and you're going to be anesthetized, there is someone that they pay just to sit there and watch you breathe, right? Okay, and that person makes a lot of money. Why? Because keeping you breathing seems to be important. Right? And so anesthetics are an example where therapeutic index is a little more narrow, right? And so we want to think about the difference between the effective dose and the lethal dose. The closer those are together, the more careful you need to be about how much you take, right? If the lethal dose and the effective dose are far apart, right, just do whatever you want, right? Because in between you're fine. I wouldn't recommend it chronically because there can be some problems, right? But as a one-time situation, it's probably okay, right? And often, as you noted, Emily, with Advil, they'll tell you to take, I mean, depending on the situation, sometimes doctors will tell you to take 8 at a time, you know, for a couple weeks even, right? They'll give you some extended, you think it's extended time, that you'll be taking some, you know, some kind of extra amount, which is probably better than taking some other pain relievers for that time. So there you go. We talked about concentration again. There's a little sort of an interesting thing that happens though, and it's this redistribution business, right? So drugs in your blood, high concentration. It's going to jump out to your organs. Blood's going to keep doing its business, floating around, floating around, floating around. As that concentration level drops in your blood below what's in the organs now, guess what happens, Kaylee? The drug diffuses back in, right, to your blood. And so you can redistribute drugs in this way, which can be an important thing to keep in mind, right? Without that blood-brain barrier, this could cause you some serious problems in your brain, right? Can you imagine some of these drugs just like fluctuating back and forth, right? I mean, it just can really cause you some problems. So you want to make sure that you're kind of keeping an eye on that. That blood-brain barrier is doing that job for you, so you don't have to worry too much about it, right? But at the same time, you want to you just want to be careful. Later, we'll talk about depot binding a bit. That's kind of an interesting thing too when we talk about binding. So not all of the drug is going to bind. I'll give you a little spoiler here. Not all of the drug is going to bind to its intended target, right? Some of it's going to bind to other tissues. It's going to be inactive, right? It's not going to be doing anything. It's just going to be stuck there. And then as your drug concentration falls, you'll release some of that drug from those depots, and you can increase your drug concentration again and the effects of that. These are important things to keep in mind, particularly when you're trying to take a drug as like a maintenance drug that you're going to be taking over an extended period of time, right? Again, we're just going to assume we all know someone who's taking an SSRI, for example, right? An antidepressant. When you take an antidepressant, they usually tell you, like, start taking this, and maybe in 6 weeks you'll start feeling better, right? Because there's some time period for that drug concentration to get high enough to be effective, right? And you want to stay up there. This depot binding is important to keep in mind while you're thinking about these things. As it binds and unbinds, comes back and forth, you want to keep an eye on that, those concentration levels. In a few minutes, we'll talk about half-life. We'll talk about a few other things that are also important to keep in mind, right? Why you take drugs once a day and twice a day and different sort of situations. All right, so cerebrospinal fluid. This is the fluid in the brain, right? Again, we're going to keep that separate from the blood. Not too big of a deal. There are a few places where the blood-brain barrier is weak. That way we can start vomiting if there's a problem. Right? Circumventricular organs is the technical term there for you. I know it's a fancy term. It just means it bypasses the ventricular system and the blood's exposed to it directly. Also important for monitoring things like blood concentration. Right, so the brain regions that are responsible for your thirst mechanisms, those are also circumventricular organs, right? They're going to bypass that normal blood-brain barrier process because you want to be able to take a quick sampling of the concentration of solutes in your blood. Make sure that you've got the right balance there. Don't worry too much about this. Here's blood-brain barrier business. We've talked about this in some detail already, right? Here's a regular capillary. Notice the holes. Here's the brain capillary. Notice the no holes, right? Not only do we not have holes, we've wrapped it in these guys, these astrocytes, right? So they can kind of pull stuff out for you, right? And provide that. So not a big deal. We have these tight junctions. you need to know this stuff. This is important things to like keep in mind, okay? Reduces that diffusion. And here's that area postrema, also known as the chemical trigger zone. That's one of the circumventricular zones. This one will actually give you projectile vomiting. So that's always a fun one. You can get this started by eating something poisonous. So, Brendan, if you want to go home and practice projectile vomiting, you can go home and eat something poisonous. It'll slide through, and all of a sudden, projectile vomiting. There you go. Right? Who's excited about that? All right, it's important to know if something can get past the blood-brain barrier, right? For our purposes, we're trying to treat things that are going on in your brain, or we're trying to change the activity of your brain to have a certain subjective experience. In either case, we want to make sure the drug we're taking is going to cross the blood-brain barrier. Can you imagine, Montana, let's think about a situation where a guy's going to sell you LSD. It's probably not going to be LSD, but it's some variation of LSD that doesn't pass the blood-brain barrier. And you've paid a lot of money for this LSD because it's good quality stuff, right? We're going to call it, I don't know, we make up some name, right? Like pseudo-LSD. And you've laid down, I don't know, a solid week's wages, right? I'm just going to make up a number. For your pseudo-LSD. This guy's like, this stuff is phenomenal. Has better binding qualities than LSD. It's got a better experience, all kinds of stuff. And he's like, oh, there's one problem though. It's not lipid soluble. And you're like, oh, okay, that's fine. That's fine. Whatever. And so you buy it and you take it, and guess what happens? Nothing. Absolutely nothing, right? Absolutely nothing happens. Why? Well, it doesn't cross the blood-brain barrier. If you don't cross the blood-brain barrier, then you don't have any effects from that, right? It seems like a waste of your money. Same thing if you're going to take let's imagine you're going to take an antidepressant. The doctor tells you this drug is phenomenal. This is one of the best drugs we have. Side effect profile is minimal, right? It's really, really effective, but it doesn't pass the blood-brain barrier. You don't really see much point in taking that, right? There's no point. So it's really important to know if you can get past that blood-brain barrier. This is important too because there are certain drugs that you might use for different situations, either to treat a peripheral issue or a central issue. Central, we mean brain and spinal cord. Peripheral, we mean sort of everything else in your nervous system, right? So there you go. There's some examples. Placenta, we talked about the placental barrier just a bit. Okay. Want to make sure that we don't... basically, anything that can pass the blood-brain barrier can get through the placental barrier, right? Okay. I know, right? So the problem with that, Natalie, is that not everybody thinks about that. There are a lot of people who are taking medications and other substances that pass the blood-brain barrier. There are certain things we know, like this one's serious, don't do it, right? Alcohol is a classic example, right? Alcohol is a classic example of a teratogen. That's what we call this, a substance that can cause a birth defect, right? There are others like valproic acid, right? Also known as, anybody know? Depakote. Yeah, don't take Depakote while you're pregnant.
Oops.
Yeah, it happens, right? And the problem, like here's the second problem, right? When are most of these substances going to have the biggest effect on the developing person inside your uterus?
The first 8 weeks.
Yeah, and what is going on that first 8 weeks? The same thing that were going on any other, 3 or 4 or 8 weeks that you had going on. A lot of people don't, unfortunately, recognize that they're pregnant until certain things that normally happen, like about every 4 weeks, don't happen. And you're like, well, that's weird. Let's see if that happens again, right? Because sometimes, I know they tell you it's happening every time, but unless you're on some kind of regular hormone, there are variations from time to time, right? Sometimes you get one, sometimes you don't. If you're not getting one as often as you should, I'd see somebody about that. But your menstrual cycle should come every 28 days, right? It should be going on all the time, but that particular phase that's outwardly observable to you should happen every 28 days, right? And if it doesn't, then that indicates something different is going on inside of you, right? Like maybe you've started growing another person inside of you. The problem is that could have happened any time in the last 4 weeks, right? And what were you doing in the last 4 weeks? Well, maybe you went to Bonnaroo, Yeah, that's all I had to say there, right? So maybe you went to Bonnaroo in the last 4 weeks, Montana, and that fetus you were trying to grow inside of you was there with you and you didn't know it, right? And you were doing some interesting things, and now what? Right? So this is why I always like to say, please don't have kids first. If you do have kids, make sure you're doing like everything you can to make sure that you're developing it in an important environment, right? And I know, like Rebecca, you already heard this like just right a few moments ago, but it's so important. I say it all the time. The other thing is, like, if you're doing things that can maybe make a kid, I think you know what those things are, take the steps to make sure that that doesn't make a kid, unless you're doing the other things to make sure that if you do have a kid, you're ready for that. Right? It's called birth control. I know some of you are looking confused. Right? There are all kinds of forms of this. You can go to a website and they'll tell you all the different kinds of birth control that are available to you. Pick one that works for you, right? Not the same one is good for everybody. And some of you don't have to worry about it, although some of you might still want to contribute to that process. There's only one guy in the audience, so I didn't really mean to single you out there and call you out on what you're doing, but there you go. That's the story. Questions about that? No? Great. None of you are going to have kids, is that right? Some of you disappoint me. In fact, Laura, some people most close to me disappoint me. Not you specifically, but maybe other folks, you know who. Yeah. Hey, tranquilizers and cocaine can cause problems with the fetus. I know, right? Shocker. Don't do that. But this is important because there are other things that you may not think about that actually can get through there. And here's a real problem. Here's where I know we're joking around like, hey, you probably shouldn't do cocaine while you're pregnant. What about if you have seizures? Yeah, right, Emily? Now we're talking about a whole different set of problems. Do you stop taking your seizure medication?
You have to see a doctor and have it monitored because those all work in ion channels and you can't just stop them.
Absolutely, right. And it becomes a much more complicated situation, right? Much more complicated. Many of the substances you take to treat medical conditions, right? And for me, I just want to be clear because I don't think everybody does this. For me, a medical condition is not just seizures or high cholesterol, but that's also depression and anxiety. Those are medical conditions in my book, so I just want to be clear about that. If you're taking medication for a medical issue that you need for your survival, you see where that can cause a conflict with the survival of the fetus as well, and that development. And it may not be, we always think about fetal alcohol syndrome, right? It's kind of like the standard, like, oh, you should have known better. But what about those individuals who were on Depakote, and they were on that for necessity? It's a different story, right? Puts a little different spin on things. So there you go. Also, X-rays and measles. Watch out for those. Why measles, right? There are certain infections that also cause problems. Here's kind of development stuff. You can think about that as you want. I do want to spend a little time on this drug depot binding business, right, or silent receptors. Okay, this is when some drug you've taken binds somewhere in the body, but it doesn't do anything, right? One of the big places that this will bind is something called albumin. This is a plasma protein, right? It's a rather big protein. Albumin is really important for maintaining blood pH, right? Picks up a lot of stuff, floats it around. Stuff hops on, stuff hops off, right? If something's tied up at a depot, not only can it not reach its active site, it can't be metabolized. Okay, so you're not doing anything with it in terms of the benefit, and you're also not breaking it down and excreting it, right? Now, this binding is reversible. It's related to concentration and time and other kind of factors that affect binding. Okay, sort of things like that. One of the things that it does is it really has an effect on duration and, of that drug action, right? Depot binding is going to drop the concentration of your drug, and it's going to delay that action, right? Now, some folks vary in the amount of depot binding that you have, which can explain different responses to the same drugs. And this is one of the things that can affect that, right? One of the big problems with this is that because depot binding is not selective, right? It's just not a selective process. When you take another drug, you can dislodge the drug that was already bound, right? So you take drug A, it binds to your albumin. You take drug B, it kicks whatever drug A was off the albumin, and then you get some strange effects, right? You get peaks at different times. Okay. This is also one of the reasons we talked before about drug testing, right? So you can, so this is important, you can detect drugs, some drugs, in the urine for many days, right? Because of this sort of delayed duration and depot binding. Okay. Here's an example of an anesthetic. Gets in, does its business, but it also sort of quickly is redistributed, binds to other sort of places, right? Gets out of the brain, so the effect washes out quickly, right? So depot binding can be, it can be good, it can be bad. It's something to be aware of, right, when you're thinking about dosing and administration of drugs. All right, so how do we get rid of drugs? Fancy word, biotransformation, right? Basically, you're taking the drug and chopping things off or putting things onto it so that it's no longer the drug, right? So that way it doesn't have the effect of the drug, right, whatever that effect is, and it's going to be more lipid soluble, right? We need to make something, or I'm sorry, less lipid soluble. We need to make something less lipid soluble so we can trap it in the kidneys and get it out in the urine, right? Can you imagine, let's think about a really lipid soluble substance. If you put that into your kidneys, what's going to happen? It's just going to float right back out, right? If you try to put that in your bladder, it's just going to disappear, right? It's going to, because everything in you is made of lipids, it's going to go through those lipids. You're not going to be able to hold on to it. Once you make it less lipid soluble, you can better hold on to it, right? It's kind of like putting a handle on the drug. So there you go, right? Now you're imagining like all drugs with a handle. So that's the way you should think about this. Most of this goes through what we call first order kinetics. I don't want you to get bogged down with this, right? There are what we call first order kinetics and zero order kinetics. There's really only kind of one example of zero order kinetics. That's when you really take in a lot of alcohol and then you go through this kind of linear process. So basically, it's kind of this concentration dependent sort of logarithmic business of getting rid of drugs, right? I'm not going to ask you to really calculate how quickly drugs are going to be metabolized and excreted. I do want you to keep in mind that this is sort of it's not a linear process, right? And when we think of a half-life, for example, it's like how long does it take to break down half of the drug that you have, right? It's not a set thing. It's not like, oh, in half an hour I'm going to break down 700 milligrams of whatever the drug is, right? Well, you'll break down 700 milligrams if your half-life was that time frame and you had 1,400 milligrams at the outset, right? So that's how this works. So you can kind of look, these are half-lives. Half-lives vary. Some drugs have a half-life of hours. Some have days. I'm just making things up here, right? There's a broad range of the half-life of a drug, right? Most drugs that you take every day, like so if you're thinking about an SSRI, these are good examples because most people are aware of them. We're going to talk about psychoactive drugs quite a bit. They'll have a half-life on the order of about 8 hours. The reason for that is if it's a half-life of 8 hours and you're taking your drug, you can get to the right drug concentration and maintain that at a once-a-day dose, right? Okay. If something has a shorter half-life, you're going to have to take it more often. If it has a longer half-life, you have to take it less often, right? And so you can kind of adjust what's going on there. All right, so over time you have 100% of your drug in your body, whatever that amount is. After one half-life, you're down to 50%, and then you just kind of keep losing half of that, right, each time. All right, so there you go. We talked about half-life business, not too big of a deal. Here are examples of some common drugs and the half-life that they might have, right? The longer the half-life, sometimes the more difficult it is to work with, right? The longer it's going to take you to get to this steady state plasma level, right? Because you're going to want to, you got to build up to it slowly, right? You can't just build up quickly and stay there. And so what you need to do to get to this steady state, you want to be putting in as much drug as you're getting rid of, right? So you can kind of stay at that sort of steady state level. It's not going to be perfect, but you want to get to that therapeutic concentration. Here's kind of a good example. This is you taking the drug, you get a little bit of a peak and then it drops, right? As you're taking the drugs at these different time points, you get a boost in concentration, but that half-life knocks it back down, right? And so what you want to do is you want to try to get to where you're at that, relatively stable, steady state, right? If your doctor has decided that you need, X number of milligrams of drug A circulating in your blood at any given moment, depending on that half-life, the way this is broken down, so forth, that'll determine the dosage and how often you take the medication. Okay? We could talk about this business on zero-order kinetics. Really, again, the only example is when you ingest a lot of alcohol. What you're doing is you're essentially saturating the sites of breakdown, and so you have a linear. It's linear instead of sort of that logarithmic breakdown, right? And the reason it's linear is because all of the sites are being used at any given time. Most of the time when you take a drug, you're not taking enough of it to fully saturate all of the places where you can break down the drug, okay? And so you're going on this other breakdown instead. But alcohol is one of the things that, because it's so lipid soluble, because people are able to administer that in relatively high doses relatively quickly, right? We sell them in these nice, great dosage packs, right? You can get dose packs of like 6 or 12 or 24, right, when it comes to alcohol. Kind of depends on your preference, right? I don't think people call them dose packs, do they? Maybe they should, right? Next time you walk into, I was wondering when you were going to get it, Natalie. I was just waiting. Next time you walk into, like, I don't know, Liquor Barn or King Spirits or
Stadium.
Next time you walk into Stadium, you don't come out. That always looks like a place you're not coming back out of. Anyway, the next time you walk in, go, I want the 12 dose pack. See what they say. I think you're going to get some weird looks, but give it a try. Let me know.
In the
You should
cashiers,
start
they'd be very
a-
confused.
You should start a brewing company and call them dose packs.
Dose packs.
Like,
Yeah.
it would be a great gimmick, I think.
Yeah.
Pharmaceutical.
Call them like reality dose. You want the 12 pack of doses to deal with reality or the 6 pack? I don't know if that's the right imagery we want to send in the world, Emily, but I think it's great. We'll work on it. All right, so there you go. Then you get kind of that straight line, not a big deal. Hey, most of this stuff happens in the liver, right? Most drug metabolism, most biotransformation occurs in the liver. There are different kinds of things we can think about, phase 1, phase 2, other things, oxidation, reduction, hydrolysis. These are going to become important to you as you talk about specific drugs. I'm going to give you a brief introduction to this right now so you can think about it, right? So typically we're thinking about, when we think about a phase 1, phase 2 situation, something that's a synthetic reaction, we're talking about putting stuff together, right? And so what we're going to do is we're going to take that drug molecule and we're going to attach some other molecule to it. What's that other molecule going to do? Well, it's going to make it less lipid soluble. It's going to make it biologically inactive, typically. There are exceptions to this. And we're going to be able to more easily get rid of this drug, right? So it's going to be something that's no longer able to bind to the receptor, bind to that site of action. And we're going to be able to package it in your kidneys and get that out of your body. Okay, so we can attach something to that. All right. So not a big deal. Here's an example of that process, right? So you've taken something like phenobarbital. You've added a hydroxyl group, so you make it hydroxy phenobarbital. Guess what this is? It's less lipid soluble. It's not biologically active. Get rid of it out of your body. Okay, it's not going to do anything. Diazepam's a little bit longer process. You've got a couple other sort of phases there. That's fine, right? Some of the metabolites are going to be active metabolites, right? So you might take a drug, and because of that breakdown process, because maybe the route of administration, the drug you're taking is not going to be the active drug, but once it goes through 1 or 2 steps of processing, it becomes active, does its business, and then it goes through an inactivation step, right? So that's kind of the exception to making things inactive. Sometimes you have to make it active. Think about like a prodrug situation, and then it becomes inactive. Does that make sense? It's not too big of a deal, right? Codeine's a great example, right? Codeine becomes morphine in the body, right? When you take something with codeine. How many of you have heard of them? Have like Tylenol sometimes with codeine, right? Okay. That codeine eventually becomes morphine. That's why it works. Okay. And that's that prodrug situation we were talking about. All right. What about liver enzymes, right? These guys are awesome. The main liver enzyme we want to think about is this, what's a family of enzymes called the cytochrome P450 or CYP450. This guy is responsible for most of the psychoactive drugs that you're going to take, or breaking them down, right? You're typically going to oxidize them. Okay. There are all kinds of members of this CYP450 family. We'll talk about specific members as we need to, right? If we say, hey, we're talking about this drug, you know, family member 2D6 is the specific enzyme that breaks down this drug, then we'll talk about that, right? And we can think about what that is. But just know most of them are in that family. If you've got a problem with your CYP450 enzymes, guess what? You're going to have a problem with most psychoactive drugs. It's that simple. That's why we might want to do some genetic testing, right? Figure out if you've got a liver enzyme issue. Okay. What are other things that affect biotransformation? There's what we call enzyme induction. If you keep taking a drug, right? Keep taking a drug over time, you'll start to create more of that particular enzyme that breaks that drug down, right? That's going to be good, right? Because your body wants to stay at homeostasis. It wants to stay at a certain level. If you're taking a psychoactive drug all the time, let's think about alcohol, right? Good example. That's going to decrease, it's going to cause changes, right? It's going to decrease some neural activity. It's going to, have some GABAergic action. We can talk about a lot of that later. Your body's not going to like that because that's getting you out of that homeostatic equilibrium, right? So you're going to take steps biologically to keep that from happening. One of these is you're going to make more of the enzyme that's going to break down alcohol.
So is that the same thing as tolerance? Because I see tolerance down there. Is it like 2 different things? Or?
So this is one of the mechanisms of tolerance. There are other mechanisms of tolerance, but enzyme induction is one of those mechanisms, yes. There are some other things that can happen, but this is a major player. One of the problems with this, Natalie, is not only when you do this are you going to have tolerance to the exact drug you're taking, but you can develop cross-tolerance to any of the drugs that are also broken down by that same enzyme, right? So if you start making more of an enzyme and it breaks down 5 different drugs, you're only taking one of those. Those other 4 drugs, if you take those later, you've already developed some tolerance to them because you've already initiated this mechanism. So that cross-tolerance is sort of is important. That's why drugs over time will lose effectiveness. It happens with just about any drug you take. right? You're going to develop some tolerance to that over time. If you want to switch drugs, switching to something in the same sort of family may not be that effective, because it's going to be those same tolerance mechanisms that you've already developed, this enzyme induction, are going to work on that other drug the same way, right? So you're not going to get that same kind of benefit. If there's another drug that works in a different way, is broken down by a different enzyme, then you can switch over, and that can help you. Does that make sense?
Yeah, is that the same with like, because this might make me sound really stupid, but is that the same with SSRIs? And can you build up the tolerance to SSRIs?
Well, certainly. Yeah. Yeah, and then once you've taken one SSRI, assuming they're all broken down by the same enzyme, the other ones, yeah, they're not going to work as well, right? Now, if they have some different action, if they are broken down by a different enzyme, then they can, maybe they can be effective, right? But yeah, you're eventually they're going to lose effectiveness. So there you go. Is that helpful? Yeah.
I figured that
Yeah. You can also have enzyme inhibition, right? Certain drugs you take might inhibit the enzyme or enzymes for other drugs. One of the great examples here is monoamine oxidase inhibitors, MAOIs. I'm going to assume most of you have not taken an MAOI. They don't prescribe those unless you have to, right? They're not really things you want to take. But most of you have taken another drug that has a warning about MAOIs on it, because almost every other drug has a warning about MAOIs. One of the things about MAOIs is because it's breaking down or preventing monoamine oxidase from doing its business, it can really has a lot of dietary issues. So if you eat things that are sort of fermented, right, like cheeses and wines, right, you can't eat, I know, right, Jillian, I mean, if you can't have cheese and wine if you're taking MAOIs, right? And I know how many like wine and cheese parties you guys go to. It's just a real problem. I'm going to say none, right? No.
I'm gonna go have one now, though, because of this.
Yeah, as long as you're not on an MAOI.
I'm not.
Okay,
Let's
okay.
celebrate with some
You're
wine
good.
and cheese.
Celebrate with some wine and cheese. You're good to go. If you wanted to bring in something to class, I wouldn't recommend the wine. That seems like that might get us in trouble. But maybe we could still do the cheese. We could do a little grape juice instead. We could have, white grape juice and, red grape juice. Give people some variety there. Different kinds of cheeses. This is probably not a good drug to take if you're on the paleo diet. Right? What's one of the key elements of the paleo diet is fermented foods, right? So I don't know that people are really thinking about that, but there you go. Most folks don't have to worry about MAOIs because, again, because of all the side effects, they're not going to prescribe them. They typically are used to treat depression. SSRIs have a better side effect profile, and they seem to be just as effective. For some people, they're not going to work, though. So maybe this is the way you want to go. Drug competition, right? So the problem here is like, here's a great example. Always take Valium and alcohol together. That way you get more bang for your buck. Just a budget-conscious individual, just do them both at the same time. Double whammy. I'm joking. Don't do that.
No, we actually, one of our pharmacists, her husband is also a pharmacist, and one of his patients overdosed on July 4th because she was on multiple drugs that, have pretty similar side effects, and then we assumed she also was drinking because it was July the 4th, and that was how she wound up in the hospital.
Absolutely. Absolutely. And alcohol is one of the best examples here. Alcohol and Valium, for example, are going to need the same enzyme to break them down. If you're taking one, you're fine, right? You've got the enzyme that breaks it down. If you take two, guess what? Probably don't have enough enzyme to handle that, right? And you're going to have some problems. So that's an issue. And then some of you are going to be genetic weirdos, right? So raise your hand if you think you're in that group. Everybody is, right? So, to some degree. So there are these polymorphisms, right? So there are certain individuals who have these sort of genetic repeats, these polymorphisms that change the activity of their enzymes. Some people are rapid metabolizers or ultra rapid metabolizers, and some people are like moderate metabolizers, and there are folks who are like low metabolizers, slow metabolizers, right? I think most of the time when they give you drugs and they assume you're a moderate metabolizer, right? That's kind of the case. There are some interesting sort of geographical and racial distributions of individuals and how they're either low or high or ultra rapid metabolizers. So it's kind of interesting.
The Asian and Native American populations are slower metabolizers of alcohol, so they're more prone to alcoholism.
Absolutely, and that causes some problems. There are some individuals from Asian populations who are, they really don't, and then there's some who don't metabolize alcohol very well at all, and they have this really like kind of flushed response. And it's yeah. So that's it's important to keep in mind, right? Again, that's why I recommend, at some point getting these genetic tests down to a level where insurance will cover them for everybody, right? Because you don't know, right? You don't know if you're a weirdo or not until
You
they
could figure it out, probably.
Yeah, you could.
If the drug isn't working as well as it should have, like that's how we figured out. Because my ADHD meds only last like a few hours, and they're supposed to last like 6 or 8. And my doctor was like,
Yep.
Okay, what are we gonna do with you? Because I was like, it's only working for like my morning class like all day. And she was like, okay, so we're just gonna have to give you.
Kaylee, light bulbs are coming on.
No, I just remembered that I have an appointment tomorrow.
Okay.
She was talking about that.
Okay.
I was like, oh my god.
Well, there you go. Thanks.
I was like, did I
Yeah,
forget
that's
an
how you.
appointment?
That's how you find out. You just take a drug, and if it doesn't work, then.
The only
then they
bad
know.
thing about that is sometimes when drugs don't work, they don't work in a really bad way, and there's some serious side effects. If it's something where the side effects aren't so bad, you can mix and match and see what's happening. Right? Take your time. Do an ADHD flight. I don't know. It's kind of like a whiskey flight. You just take a little bit of everything and see what works. Which I think is actually, unfortunately, especially with depression, that's the approach, right? It's like, well, we've got like 8 drugs we can give you. Let's start with this one, and come back in a few weeks and see if you're feeling better. If you're not, we'll switch you over to drug number 2. We'll see what happens, right? You like the single malt, or you like,
Do a little sampling.
Yeah, right. So there you go. Something to be aware of. Ultra rapid, there you go. These are just some numbers. You can see things. Here's the one that kind of breaks down, different racial groups and the presence of ultra rapid or extensive or intermediate, so you can kind of see what's going on. Not a big deal. Something to keep in mind. This is looking at a specific drug, or specific enzyme rather, CYP2D6. So that's part of the CYP450 family, but it's 2D6. That's the specific member of that family. Okay. And there's different letter number combinations for the different members of that family. How do you get rid of drugs? You pee. It's the best way to get rid of drugs is just to pee. Urine's the number one elimination route. There are a few other places where drugs can come out. Breath is sort of the other way, right, that you might think about this. But urine's the number one way. Not a big deal. Once the drug has become less lipid soluble, then you can trap it in your kidneys. You can send it out your body. Not a big deal, right? This is why they use urine for drug tests. What about therapeutic drug monitoring? Here's a shocker. Some drugs your doctor needs to keep an eye on, right? Just to make sure you're at the right place and you don't have too many side effects that are too bad. We're not going to just take a drug and come back 5-10 years, see what happens. We talked about therapeutic index, right? The narrower that therapeutic index, the closer the effective dose is to the lethal dose, the more monitoring you need. Okay, your doctor's not going to monitor you if they send you home with Advil. Okay, you're going to be fine. Advil, the therapeutic Index is like from me to Montana, right? That's the safety margin on that. Safety margin on LSD is like from me to Taze Valley. So it truly is. You can take like a 20,000 times higher dose of LSD than required to, I know, right, to have some effect of that and still be fine. You can't do that with cocaine, right? Therapeutic index on cocaine is pretty narrow. Heroin, pretty narrow therapeutic index, right? So there you go. Monitoring is important. What are some other words? Receptors. We talked about receptors. A ligand, that's a fancy word that is just the molecule that binds to a receptor. Okay, so we can use the word ligand, and when we say, oh, when the ligand binds to the receptor, here's what happens. Why would we use the word ligand instead of drug? Well, ligand, we might be talking about the endogenous molecule that you're making, right? That's a ligand. The drug's a ligand as well, right? And we can just talk about ligand receptor binding. Most drugs don't actually get into the neurons themselves, right? Once they're in the brain, they just kind of attach to receptors that are on the outside. There are some exceptions to this. I don't think we'll talk too much about them. Some hormones get in and do some things. They have to actually get into the cells. There you go. This is like the most simple diagram ever, right? Drug, receptor, effect. That's it. And really, this is it. I mean, I know it's a simple diagram. You've got a drug or a neurotransmitter, doesn't matter which one. It's going to bind to a specific receptor, and that's going to cause something on the inside of the cell to happen. Okay? That formula is going to be true for every single substance that we talk about for the next, 13 weeks or whatever. Okay? It's a 3-step process. You got a ligand, you got a receptor, you've got an effect. There you go. That effect can get complicated. That receptor can be very elaborate, and that ligand can be pretty elegant as well, right? And it can be altered to do different things, or do the same things differently, I should say. Here, that's the example with the steroid hormones. Those guys do have to get inside because they'll start screwing around with your DNA and stuff. So we'll talk about those as we need to. The concept of affinity is kind of important, so we can spend a little time on that. The higher the affinity, the more strongly two molecules will bind. Okay, it's that simple, right? So let's think about how many of you have friends. If you don't, you're aware of the concept, right? So my assumption is you have, I'm going to make up a number, 10 friends. Okay. I know that sounds like a lot, but I need that many for this example. But not all of those are your best friends, right? Maybe 1 or 2 of those are your best friends, and then you've got, those are the ones with the highest affinity for you, right? So those are the ones who you're most tightly bonded to. Then you've got another sort of ring of people out there, right, who are your friends, and they're friends that you'll help, but you won't help at 3 a.m. Right? You'll help them between the hours of noon and 5 p.m. Right? So you got those daytime friends, right? And so that's kind of the ring out there. But then you do have those really close friends that whenever they call you, you're going to go help them, whatever it is that they have going on, right? So higher affinity, more tightly bonded, less affinity as you move out, right? And it's going to be the same with these molecules. Some of them are going to have really high affinity, some are not. The scary thing is, most of the synthetic molecules that have been created have a higher affinity. This is why they're more powerful, right? Like, why would you take a drug? Because it works better than the molecule you make inside your body, right? So it has to have a higher affinity. The problem with a higher affinity is that I mentioned the part where it works better and it works faster. And so the potential for abuse is higher, right? The potential for adverse effects is higher because it's working more powerfully, right? So you can run into some issues there. We do want to think about the idea of agonists and antagonists. Okay? This is pretty straightforward. An agonist is simply something that increases the effect of a neurotransmitter. An antagonist is something that decreases the effect. Okay? There are 1.5 million ways that you can do this, right? Okay, we'll talk about some of those as we go along. Here's agonist, antagonist. Basically, an agonist binds and nothing happens. Or an antagonist binds and nothing happens, right? It blocks the site. It blocks the site from being activated by a drug that would do something, okay? Partial agonist, inverse agonist, these are all sort of important concepts. I want you to spend some time on it. Basically, we're at the point now where we've realized, hey, giving people dopamine is not a great idea. And why is it not a great idea? Well, yes, it prevents you from having tremors associated with Parkinson's disease. That's awesome. You also start hearing voices like you have schizophrenia. That's probably not so awesome, right? The reverse is also true. If someone has schizophrenia, why don't we just block their dopamine, right? Because that's going to prevent them from having these hallucinations and other positive symptoms. Awesome. Then they develop a movement disorder. That's not so awesome. So you can give people these partial agonist, partial antagonist, antagonist-agonist combos, right? Things that kind of work differently. Because we are better understanding the molecular structure of the ligand and the receptor, we can start to tweak that a little bit, right? And what we're doing with these partial agonists or antagonists is we're giving you something that works, but not quite as well. It works better than nothing, but not quite as well as like the full drug, right? Or the full dopamine, or the full agonist or full antagonist. So we give you something in between, right? Helps you out a little bit, doesn't quite get you there all the way, but you'll get by. It's pretty fancy. Previously, we just said, oh, you hear voices? Stop taking the L-Dopa. Oh, you're shaking? Let's try taking the L-Dopa again. See if it works. So there you go. This is kind of a nice little breakdown. You can study that a little bit if you'd like. Again, lots of ways agonists and antagonists work. Binding is temporary, right? So when a ligand is bound to a receptor, that doesn't stay that way forever, right? Molecule will release at some point. Affinity influences how long it binds, okay? Upregulation, downregulation simply means you're making more or less of something. You can do this in response to the presence of the ligands or the absence of the ligands, okay? This is also, Natalie, a mechanism of tolerance. Okay, if you downregulate receptors because you have a whole lot of the ligand present, that's a mechanism of tolerance, right? If you've got a bunch of dopamine, why do you need more dopamine receptors? You don't. Fewer dopamine receptors will do the same job, so let's move that down a little bit. Okay. Lots of receptor subtypes. We're learning more and more about this every day. It's not just dopamine receptors, there are D1 and D2 receptors. Not just opioid receptors, we've got mu and kappa and other things, right? And as we learn more about each receptor, we realize each receptor subtype does something slightly different. It has some nuanced effect. Okay. Dose response curves, not a big deal. As you take more of a drug, you get more of an effect up to a certain point, right? The more caffeine you ingest, the faster your heart beats. But there's a certain point where taking more caffeine is not really going to get your heart beating any faster, right? Not a big deal. We can use that with potency. These are dose response curves for different drugs. Notice something like morphine, you can take less of it and get a bigger response than aspirin. You got to take more aspirin, right? It tells you something about the potency of the drug. Therapeutic index, we've talked about this a bit, so I don't feel like we really need to go over it too much. Competitive, we should probably talk about this. Let's stop there for today. Thursday we'll pick this up, and then we will just a bit and go from there.